Yep. Kathy, Dr.
Yes,
Levine
okay.
said he'll be in and out of this.
Into
so
something else. Okay,
Dr. Levine will be in and out.
great, so I'll turn it. Okay, and we are recording again, and the chat will be turned off. So I'll turn it over to you, Allison, if you've got the questions.
Sure. So Tracy, there was a lot of discussion about the role of the peer community in this type of model. And so one of the questions on here is around peer credentialing. And if you have any take on what are the pros and cons of peers billing Medicaid for these services?
Yeah, excuse me. I think that I don't have. I would love to hear people's responses and your reflections on that, Allison, because it's an important question that I don't have a formed opinion on right now. I will say that one of my opinions that isn't directly answering that question, so I'd love to toss that back to you and get your reflections on it. But I do believe that in keeping with the grassroots movement concept, that in addition to the procedure, the process for that, having really like peer groups that are led by, people who are champions who may not have any formal training except perhaps taking our training, has to be a part of the mix if we're gonna scale it. But that's more like community-based, join a group, the AA, Al-Anon kinds of concept. But I don't have good reflections on the question that you posed. What are your thoughts?
I think what I love about Vermont is when we say we have these conversations, we have these conversations in person because we're such a small state. We bring lots of folks to the table and we get to know each other. And the debate that I've heard is a peer service is supposed to be different in that it shouldn't feel the same way for the person entering it as it does in this hierarchical, I'm the clinical person, I'm here, here's my degree, and I am telling you. And then, but we want to value that service and pay for it. A way to do that is to put it under the Medicaid umbrella. But the minute you do that, you're forcing it into a medical model that has to come up with medical necessity. And so I've heard, at least from the peer community, that they're feeling like, I want to stay out of that. How do I fit? How can I be valued? How can my services be paid for without having to have it feel like the same entrance into a system?
Mm-hmm.
I'm curious if others have thoughts on that. Did I summarize feelings correctly?
Allison, this is Bart. I can't speak to the feelings, but I will observe that our department pays for many things using Medicaid funds that I would not call the medical model. So if we step out of Medicaid and view it as a funding source as opposed to a cultural guidepost, that might be a question. Is there a way to use Medicaid funds where it doesn't feel medical? And I think there are examples of that, even though that's the tension. It's my experience that Medicaid has evolved since 1965 very substantially.
Thank you, Bart. I do appreciate that. And I think at some point it'd be good to dig into some examples. I see Andy has his hand up as well.
Yeah, then I took it down. I have about 3 pages of notes of things I wanted to say if I was Tracy, but that's for another time. Just on this one in particular, and I had a conversation recently with one of the people leading the evaluation of CCBHs, that there are certain positions, certain functions within the team that should not be dependent on direct billing for services. That you need certain functions. They're really, a lot of the really critical functions are not reimbursable functions. They're not, encounters, billable encounters. And the system needs to come up with a way to do that. And there are other ways to make money on the capitalist system, but not with peers.
That's well said.
Allison, I'd only add that there are many ways to pay for things under Medicaid that are not encounters. And so that's maybe to consider this in a payment reform kind of model and some of the payment flexibilities. And there are some examples of that because, yeah, you don't want to be sort of tainted in Andy's term. It sort of implies that, right, that you turn it into this encounter thing and documentation. So there may be ways of pursuing Medicaid reimbursement that do not taint the experience or the practice.
Well, I appreciate that because it dovetails into another question. We've had a lot of conversation, but pretty recent conversation on CCBHCs. And Tracy, I assume you know what that is, but if you don't, please let us know.
Can you
about
make sure
that.
I do? Can you clarify? Make sure I do.
Yeah, so I'm probably going to mess up so it's what's considered sort of cost-based reimbursement for certified community behavioral health centers. So it's a different model. And if you don't know a lot about it, feel free to defer this question. But the question came up as, have CCBHCs entered your world, and has it been any part of this?
So I think the answer is no, because I'm learning about it from you. So it's a real blind spot of ours. So I appreciate knowing about it, and I want to learn more. And I don't know if you want to take time on this Q&A to say a little bit more about it, but I'll look forward to learning more about it.
I'll just quickly say it's a model promoted by SAMHSA, and the goal is for integrated health, and the focus is really mostly on substance use and mental health, but there are other opportunities, and it's a different way of paying for that type of integrated service.
Got it. Thank you. I'll look forward to learning more. This is good. This is how I learn, so I appreciate it.
Yeah, no problem. A third question that came up: what kind of resources, particularly transportation, are needed for the referral out system that you talked about? In a rural state, it becomes more complicated, and would love to hear any thoughts about that.
Yeah, a huge issue. And also, I mean, I don't know how the situation in your rural communities, but here, and I was in Idaho before, living in Arkansas, another very rural state, we had issues even with just broad, people having enough internet access, because people are quick to say, well, you don't need transportation, just do it all virtually. And a lot of this can, of course, be done effectively virtually. The groups can be virtual and et cetera, but not if you can't connect. And again, it's another area where I completely agree with the challenge. I don't know how to resolve that. And I kind of turn it to the group to say, how are you all thinking about it? And is the connectivity an issue in Vermont like it is in Idaho? And yeah, I guess that's true across the board. So how do we solve that? I mean, that's huge. You can't have access if you can't either get transported or have a virtual access. I'm not answering any of the questions. I'm just asking more questions. But it's good to be in it together. And I'm sorry, they're now cutting the grass outside my window, so you're probably going to hear some background noise. I apologize.
Oh, no problem. I mean, it's actually validating to hear you haven't solved rurality in the system of care. Something we're seriously working on, and broadband is an issue in many parts of the state. I will move on to the next one, which was an interesting question about how multi-generational work can be incorporated into the whole health system. Do you see families? Do you think about it in that type of family system way, multi-generational impact?
Yeah. My own, there has been kind of a push, and this won't surprise anybody. There's an argument that says, oh, we should organize these groups, these, whole health groups around conditions. So everybody that's got, a same diagnosis belongs in that group. The same has been true. Well, or maybe we should do it generationally, like splitting generations. And I think, my belief is, and I don't have data to support this, although there's probably data out there, that in a whole health paradigm, a big piece of what's different is, again, it's not the hierarchical top down, the doctor or the clinician is going to tell you what you need to do. One of the core distinctions in this approach with the self-care side of things is you start with what matters most to the person and that what they are drawn to. And this is hard for some doctors more than the other health professions because we're trained, again, it's not a criticism. We're trained to say, okay, here are your risk factors and target the most significant and try to focus that on that. If you're a smoker, you're going to put your energy to trying to convince the person to stop smoking as an example. But part of what's different in this model is when it really starts with the person. One of my friends always says, go where the water is flowing. So, if somebody's a smoker, but they're not ready to take it on, don't go there. Not like ignore it, but don't push your agenda. Let the person, it's behavior change, right? Let the person identify what matters most to them and their doorway in. And then what you quickly see is it's a system, right? So if people start to feel better in one aspect of their life, like they take on sleep and they actually make progress. And now they have more energy to address the harder things in their life. So I think it's the holism of this approach would mean it's also holistic across generations, across cultures, and across, definitely, let's not split people into their diagnosis. That's where we often go wrong. So, and the work that we'll start to do with the younger generations will be really interesting in that regard. But I think the more diverse the groups are in all sorts of ways, the more magic, the more people can learn from each other in unexpected ways.
Thank you. That's great. There was a question that came in, and I'm going to try to ask it in the way that I can conceptualize it, but it gets at parity and pay and issues of equity in the system. So I'm curious, when you start talking about treating someone in a holistic way, does it bring to the surface the reality that mental health services are often not reimbursed in the same way that health services are, and that mental health workers are often not paid in the same way that healthcare workers are? And so we're talking as if everyone's just coming together, but yet a business model might want someone to have a healthcare diagnosis or oversight by a healthcare provider. How do people equally work in that sandbox? And when you embrace this philosophy, is it also a chance to fight for more parity, both in reimbursement and in pay?
So I love that question because I haven't thought of it in that way before, Allison, and I think it's a really important and profound thing to think about. Again, we get what we measure, we get what we pay for, right? So oftentimes in my work across the years, especially if I'm doing like public speaking to healthcare audiences, I will start by apologizing that I'm getting listened to in part because I'm a doctor. And I am saying things that entire professions like nursing and social work are rooted in. I mean, this is, you know what I mean? And it's like, oh, now suddenly it's a big idea because the doctor finally got it. And so it's such a challenge in the culture that there is this hierarchy, and the real shift is changing that the system values what's already there, but isn't designed to value, right? So, and that gets tricky, right? Because now you're starting to threaten people and say, oh, the doctor is not the most important one in the room, but I would say the doctor is not the most important one in the room. And it becomes challenging. And it also underlies, we were talking before about the challenges of turf and people, this understandably feeds into, are we equals at the table? And what does that mean if we integrate? And, again, I think at an unconscious level, a lot of the time, but that's understandable, right? That gets baked in and is a part of the challenge. And I think there's real power in naming it, not like we have to fix it, but I think because it's baked in, but I think it's like making it conscious and naming it so that everyone is like, okay, at least we named that. Like I can feel when I'm that little example about saying, yeah, I apologizing to all the professions in the room who've been practicing and valuing this all their lives. I can feel people relax. I can feel people go, thank God she realizes it, thank you for realizing it. And hopefully it's not my fault, that the system is that biased, but naming the bias allows it to be conscious in a way that I think is really important.
Yeah, well, and it's a start.
Yep,
Right.
it's a start, right? I mean, being able to say it and name it and look at it together, that's respectful. It's to say, yeah, I mean, it's like all the other discrimination work, like, yeah, let's start by being honest about it.
I'm going to switch gears a little bit to the world of disability and disability services. And one of the questions that came in was, in disability services, we see people for much of their lives. Thoughts on integrating at the level of complexity that comes with long-term care and physical health?
Oh, I love that question a lot. Yeah, I don't think the group on this call, I'm going to say what often happens when you talk about whole health or holistic approaches to care, et cetera, is that there's a presumption that, another story came to my mind, I'll have to share it. There's a presumption that it's really, we're talking about prevention only, right? Like that applies if you're, healthy, or if you're, you have enough resources to think about such things, et cetera. And I think that the most poignant part of the work is often with long-term care, right? Where people are so embracing these questions of what matters most to them. What do they want their life for? What these kinds of questions that go to their heart and soul. And typically the experience is, wow, thank you for asking and letting me think about what does it look like for me in my condition, in my long-term care situation, to optimize my well-being, because it's not just physical, it's not just mental, and so I think it's very critically important to find those kinds of to see it in play in the most complicated circumstances. It's often the most amazing opportunity to see the impact. And yeah, it's one of my pet peeves when people think, or I'll just tell this really quick story. I was in a health system, in a VA health system in New Jersey, and we were talking about this, changing the conversation to help people explore their sense of meaning and purpose and what really matters to them. And this kind of snarky woman, you can hear all my biases now. The snarky woman raises her hand, and she says, well, if I asked my veterans what mattered most to them, they'd say hanging out with their buddies and drinking beer. And she said it with such disregard and disrespect. And I said, and what's wrong with that? And you could feel people go, oh shit, oops, sorry. Oh shoot. It was an other moment. But and I said, so I wonder what about that hanging out with the buddies and drinking beer matters to that person, right? Maybe it's feeling connected, maybe it's feeling valued, maybe it's having someone to laugh with or cry with. I mean, shame on us for thinking that this is this is only for some parts of our society. Couldn't be more wrong.
Yeah, I appreciate that, because it goes towards understanding culture on what brings people together, and that's different for very different people. We actually we got an interesting conversation of when you bring up the term meaning and purpose in your life, how does that dovetail with spirituality?
Yeah.
And how does the medical community or human services community grapple with asking questions about that? I was telling the group there was a magazine cover a few years ago, I think it was Time magazine, that said, "Are you there, Vermont? It's me, God." And the point was how atheist and agnostic Vermont is in compared to other states, and how just we have more of a lack of organized religion, and many folks don't adhere to it compared to other states. And so what do those conversations look like when you bring up meaning, when you go to see your doctor? And how do you figure that out in creating a definition for spirituality and a role for that meets a person's, personal definition?
Yeah, it very apropos. And of course, here we're in the Bible Belt, so there's a whole nother dialogue here about how dare you, push the bounds outside of, the Baptist, Southern Baptist approach, which is a challenge. But so I think we're still learning around languaging, Allison. Like for some people, purpose just is too overwhelming. Like that, like, oh my gosh, like I have to figure out my life's purpose sounds like massive. So that, you've heard me say sometimes, well, what matters most to you? That's a more, a less intimidating, way of really getting at the same thing. And then having people, oh, drinking beer with my buddies. Okay, well, what about that? Doing the peeling of the layers. What about that matters to you most? Otherwise people will give pretty superficial responses like, well, my family matters. And it's true, but it's not deep enough to actually drive behavior change. So I think how we question and ask those things, and then in our work, we're really defining spirituality in a very broad sense. Where do you go during times of stress, or where do you find a sense of meaning and purpose? And a lot of times it's nature or music or church, or, and helping people understand that broader purpose. I just looked at I have a little sticky. I'm obsessed with stickies. I have them everywhere. Because I'm fixated with this question, how do we best pose these questions? And I think it's going to be different, but the language that the Aspen Institute is using, which was interesting to me, they are using purpose, meaning, and then they're also well-being and belonging. And I thought that's interesting. Like, I think that's part of how they're trying to broaden it so it doesn't get so overwhelming with meaning and purpose. So purpose, meaning, well-being, and belonging. I thought that was a very interesting paradigm or a frame.
Yeah, I appreciate that. I know a lot of people out there, especially due to the pandemic, their drive right now is stabilizing, getting
Correct.
through the day. And so to be asked what your purpose is could throw people into this existential
Exactly.
crisis. I'm supposed to have something more than that.
Exactly.
I'm going to squeeze one last question in because I think we have time for it. And it's hopefully a simple one, which is who has to be in charge to make this work? I think the question there was two questions around this, which is, do we build bridges between our silos or do we knock them down? And when you think about either of those, you either have to have some authority that's saying, yes, we made a referral. Do you have any say over what happens with that referral? Are any of these entities all under one umbrella? Or is it truly just a network that's all, and you're just building bridges between the different organizations? And do you need an oversight? Like, would you be setting something up from a state government point of view that oversees any of this or any other entity?
That's not a simple question. I think in my 1 minute, so I think that it has to be grassroots, network driven. Now, I do think you need the top down that aligns with it, but I don't think it's going to be driven by the top down. And one last comment I will squeeze in, Allison, is, one of the things that we shifted in the way we think about it is going from, because if the person themselves is actually the driver, if the person that that is truly at the center and they're the driver, that becomes the integrator, right? That because they're not split into their body parts or their mind over there, or that if we can shift the frame, and I actually don't even use person-centered anymore, because even that, patient-centered, person-centered, even that implies you're in the center, so that's better than you not being in the center, but we're doing things still to you. Person-driven flips that. So the person and what they care about and what matters to them as the driver for their care, healthcare and self-care. Again, easy to say, hard to operationalize, but boy, when you can flip that, a lot of things fall into place.
That was a great answer and a good way to end this rapid fire session. Thanks for sticking with me, Tracy. I know there was a lot. So
I loved it. I loved it.
Great. Yeah, thank you so much. And we will follow up as much as you have the bandwidth for. We've got a number of other questions.
Sure.
So thank you, Tracy. We are going to go into our work groups now, and